When you're diagnosed with kidney cancer, survival becomes the focus, and fertility, it's often not a part of the conversation until it's too late. In our final episode of the season, we sit down with Dr. Kara Goldman, a reproductive endocrinologist who helps patients protect their chance at future parenthood. We talk about what we know and what we don't about how kidney cancer and its treatments affect fertility. We cover everything from the potential effects of immunotherapy to whether living with one kidney can complicate pregnancy, and why fertility should be a part of the treatment discussion from day one. We also explore the emotional weight of fertility decisions, including the uncertainty, the grief, and the hope of imagining life after cancer. That's a wrap on this season of Kidney Cancer Unfiltered. Thanks for listening, and stay tuned. We'll be back with more stories you won't want to miss. Well, Dr. Goldman, thank you so much for joining us on Kidney Cancer Unfiltered. For our listeners, if you could introduce yourself and your background, that would be perfect.
Absolutely. Thank you so much for having me. I am Dr. Kara Goldman. I am a reproductive endocrinologist and specialist in infertility at Northwestern University. I direct the fertility preservation program here. And so that means I take care of patients struggling with infertility and those who are at risk of infertility because of treatments such as those for cancer.
Now, fertility is not necessarily something we talk about often in the kidney cancer space. And I know for myself, what's interesting is that when I first had after I had my nephrectomy in 2020, I had spoken to my gynecologist and asked her, "Hey, what would pregnancy look like for me after this?" And her face like got very like stark and was just like, "No, not at all. Like you should not do that. Like having one kidney and your age at that time, I was 37, and your age, it'd be too high risk. I wouldn't do it." And so that kind of put the squash on it for me. And I came to terms with it until like last year when I spoke to another fertility doctor at another cancer conference, and they're like, "That was the wrong advice you should be given, that you should have been given." And I say that to say, I think that often kidney cancer, so I've had this conversation with others, hear it in those terms of like, well, you have one kidney, you shouldn't do it. It's not something, or I hear from others like, it's just not a conversation we have. So I would love for you to talk about some of the ways that fertility is impacted by kidney cancer and kidney cancer treatment.
Yeah, absolutely. And I'm so sorry that that was your experience and that you've been through all of this. I will say that, certainly everyone's experience is different and everyone's planned treatments are different. But if I am meeting a patient for the first time who has a diagnosis of kidney cancer, there are a number of questions that we need to ask to figure out, how can we think about fertility? The first is, what are the treatments that you will be having or have had, and what is the impact on the ovaries? Will you have lost ovarian function? Will you have ovarian function after your treatment is complete? And we can talk a lot more about that. Will your treatment delay your plans for childbearing? And so if you were 37, the question could be, if you're going to be spending years in treatment and then you're 40 or 42 when you've finished treatment, which I realize that's a very long timeline, but, will you in some ways age out of fertility and childbearing? And that would be an indication for fertility preservation. Will carrying a pregnancy be safe? It sounds like in your case, and maybe in the case of others, there's the fear of, if you have one kidney, what would be the risk in pregnancy? And there are certainly people who are pregnant and have one kidney, and as long as you have good kidney function and a nephrologist who's comfortable with you being pregnant, then that should not be a contraindication to pregnancy. And then, will your surveillance plan be different in pregnancy? Can you get all the scans that you need when you're pregnant, or is there a risk that you can't get a scan and then there could be something missed? And then kind of beyond that, is there a risk that the treatment you're facing will affect your sexual function, and will that affect your kind of ability to try to get pregnant? And so when I'm having a conversation kind of upfront about, risks of any kind of cancer treatment on a patient's fertility, I think that we can really focus on, is a child in your future plans? Like, do you hope to have a child one day? And regardless of what kind of fertility or what kind of cancer treatment is planned, we can think about preserving fertility so we can keep those doors open.
Now, how does the different, like, what are the differences in kidney cancer, like impacting fertility, um, in men versus women when it comes to treatment, and also versus other cancers, right? Because I do think, um, given that for many stages surgery is just, is the treatment. I don't want to say just, but it is the treatment. It's not necessarily impacting our reproductive organs, but at the same time, going back to having one kidney and carrying, it would just be great to kind of understand the differences both between, I guess, reproductive organs, if you will, and also between cancers.
Yeah. I think when we think about surgery and nephrectomy in particular, the main the main concern really would be, is there, any risk of scarring in the pelvis?
Okay.
And could that then impact the function of your fallopian tubes and your ovaries? And of
Okay.
course, it would depend on the approach to nephrectomy. So if this is an abdominal surgery and, you've got a big scar in your abdomen, that's going to be different than if the surgery is, a posterior approach. And again, the caveat here is that I'm not an oncologist and I'm not a nephrologist, or urologist, but I take care of patients who've gone through all of these things, and so I can kind of address it from that perspective. But if you have a pelvic surgery or an abdominal surgery, and there is an infection after the procedure, or just from all the manipulation of the tissue inside the body, that can cause scarring, and that can potentially block a fallopian tube, or inflammation in the pelvis can affect the ovaries and potentially ovarian function. So that's really the main way that we would worry about surgery impacting it. Now, in someone with more advanced disease who is going to be taking checkpoint inhibitors or tyrosine kinase inhibitors and all of these immune modulating agents, then we have to think more about what is the impact of those drugs on the ovary. And that is where we also think about the impact to male fertility. So the same reason these systemic drugs, these immune drugs and biologics and immunotherapies can affect the ovaries, they can also affect the testes and affect sperm.
So, can we talk a little bit more about those targeted therapies, immunotherapies, and how those used in kidney cancer treatment affect like both, again, the reproductive organs or even just hormone levels, right? It's not just necessarily the uh the physical mechanics, but also everything else. Yeah.
Exactly. So let's start by taking a big zoomed out view and just talking about ovarian biology
Okay.
very briefly, and then I can talk about how we think those drugs might play a role. So essentially, you've got a limited number of eggs in the ovary. People with ovaries are born with about 1 million eggs in the ovary. And actually, by the time you're born, you've lost a tremendous number of eggs because you lose them in utero. So when you are a fetus, you're losing eggs. You're born with 1 million, you have 300,000 eggs remaining at puberty, and then only about 1,000 eggs remaining at menopause. And every
Mm.
month you ovulate one egg and you lose 1,000 more, and there's this progressive loss of egg cells until menopause. And most traditional chemotherapy drugs, so if you're thinking about how breast cancer is treated or other common cancers that use these traditional chemotherapies, they actually cause a loss of egg cells. So you are going to just lose egg cells, and some women are going to go through menopause early or lose ovarian function entirely after their chemotherapy treatment. We're not seeing that with immunotherapies and with these
Okay.
checkpoint inhibitors. And so we're not seeing that same impact, but we also do not have enough data to really understand the impact. And part of the problem is that when you look at clinical trials that are done for new oncology drugs, there are a number of endpoints that are looked at. We know the impact on heart function and on lung function, but the ovaries are not a required organ to study.
Hmm.
And so most clinical trials, by the time they get out to the public, there are no data on the impact on ovarian function. And so all we know about the impact is what we know from looking back at patients who have been on these drugs and then saying, okay, what happened to their ovarian reserve? So the long answer to your question is that we don't really know. Um, the big long-term impact of these drugs on ovarian reserve, on age of menopause, on function of the ovaries, but we know that most people after taking these drugs will still have function of their ovaries. We just don't know to what extent.
So, why do you think, I guess, fertility is more of an afterthought and not something really talked about? So, I've spoken to other survivors, not in the kidney cancer space, although some in the kidney cancer space, more of, ovarian cancer and whatnot, who maybe 10, 20 years ago had it, and we're told that like fertility wasn't even a thing they talked about. They weren't even given the option for fertility preservation. Doctors just decided, hey, I'm going to take the whole thing. And it seems like it's gotten better over the years, but there's still this lack of discussion, and more so, I think, in kidney cancer than in other types of cancers about fertility and fertility preservation. Why do you think that is? Why do you think it's such a somewhat, it seems like a taboo subject, if you will?
Yeah, I mean, it is really heartbreaking when you look at the impact of infertility, on patients who have survived cancer. It is one of the most challenging parts of a patient's cancer journey. And, not, and I know I'm speaking to patients with cancer, so not to put words in your mouths, but when I take care of patients and they think about, when they are newly diagnosed with cancer and they think about, why is this diagnosis so devastating for so many of them? It's because of the potential impact on family building. And when I talk to survivors, they look at this as, this was one of the most devastating parts of cancer was the impact to my fertility. So why is it under-recognized? I think it's because maybe it's considered this kind of an elective piece of the bigger
Mhm.
puzzle. When you are thinking about survival and you're thinking about a new diagnosis, there may be a bias in your care team saying, let's just get you through treatment and get you started, and we'll think about these things later. The problem is you can't think about it later in cases where you're going to be treated with a medication that it will permanently affect your ovaries or your sperm. So I do think that the cancer community has absolutely, made a huge push in making this a priority. It's a priority, based on the NCCN guidelines and ASCO, and, a position statement is put out every few years, basically from ASCO saying that talking about fertility and fertility preservation is a critical part of comprehensive cancer care. So we know that this is a priority that's being recognized, but we're still only seeing a small subset of patients with diagnoses of cancer coming in for fertility preservation counseling. And so there may be a bias in referrals. There may, a big part of it is insurance coverage and cost. And so there are only a minority of states where insurance will cover fertility preservation. So maybe it's on someone's radar, but they don't think they can afford it, or their physician doesn't send them because they don't think they can afford to go through treatment. And then geography. So, there's a big problem with geographic access to fertility preservation. And when you look at the centers that offer fertility preservation and where patients are in the country and where they're getting diagnosed with cancer, there's a total mismatch. You've got a huge swath of the country where they would have to travel across state lines to access fertility preservation care. And when you're going through an initial diagnosis and going to, a myriad number of appointments and trying to just get through each day, I think you can see how it can get pushed aside.
So then how do we kind of close those gaps, both like geographically, both within like how doctors treat fertility, and even patients advocating for themselves, right? Because again, it's for myself, I can say that while it was on my mind, I wasn't thinking about asking it before surgery. It was kind of like diagnosis a month later, surgery, and then it's like, oh, maybe I should ask about it.
Yeah.
So I think even for cancer patients, it's not necessarily something you want to think about right away too, because you're trying to go through this. So how do we close those gaps?
Yeah, that's a great question. And I think that, primarily we think about education and, educating both physicians who are taking care of patients with cancer to make sure they know how to access reproductive endocrinologists who can help to talk to patients about fertility and preserve fertility, educating patients, making sure that you understand what's out there and what your options are. I hate though putting the burden on patients. You already have so much that you have to think about at that initial diagnosis that the last thing you want to have to do is advocate for yourself on one more thing. And so, institutions have adopted a system to try to make this easier for physicians. We have a patient navigator at Northwestern. We have a patient navigator who basically is the go-to for all oncologists who can reach out to her and say, hey, I've got this patient with a new diagnosis, and she will then contact me or one of my partners and say, can you get this patient in today or tomorrow to talk about fertility? And so, by making it easier for oncologists who already have a lot on their plate, then we can hopefully close that gap. And then from a geographic standpoint, I think we need to think about, how to bring care to patients. It's something that I'm thinking a lot about, ways to make our care more accessible. And, when people are thinking about where to open new centers and, build, fertility centers and clinics, I think we need to think more about where these gaps are. But I also think that there's, it depends a lot on the specific diagnosis. And if we're talking about, kidney cancer, where it starts with surgery, and then you might have some time after surgery before you theoretically might need some other type of systemic treatment, some, medication treatment,
Mhm.
that could be a window, to do this. And we wouldn't need to preserve fertility before nephrectomy, you know, because there's nothing that will happen at the time of nephrectomy that will influence fertility in the short term, or,
Mhm.
really that risk of infection is more, or risk of scarring would be more theoretical. Really, the worry would be, you know, how long will you be delaying childbearing? So, will there be a long delay because you have this diagnosis and you're not, cleared to be pregnant for X number of months or
Okay.
years? Or if you're going to be facing some kind of treatment like a immunotherapy, that would be a time to preserve fertility.
Now, I know you've worked with some kidney cancer patients on fertility and their pregnancy journey. Could you talk more about kind of what was the process? And I know their, situations were unique, but generally, like, what was the process in helping them get to pregnancy and childbearing?
Yeah. So, typically the time that I would meet someone would be after they've already been diagnosed, they've already had their nephrectomy, and they're thinking about, how do we plan ahead for a pregnancy? And, especially if I'm going to need some kind of immunotherapy, what should we do? And so that is a perfect window to think about freezing eggs or freezing embryos. And so we can talk about, what a few of the options might be. So one option would be if you're cleared for a pregnancy, let's say your oncologist says now is a good time to be pregnant, and maybe we want to expedite pregnancy. We can think about in vitro fertilization, or we could even think about expediting pregnancy by using some other tools like drugs to help someone ovulate, and then do what's called an intrauterine insemination, where you put sperm into the uterus.
Okay.
But let's say in the case of in vitro fertilization, maybe someone knows they want to have children, they can't have children now, they need to wait a year, and maybe they will be exposed to immunotherapy drugs. Then we think about freezing embryos or freezing eggs. And that process is essentially a 2-week process where the patient injects themselves with hormones that are similar to the hormones that your brain sends to the ovaries. So, follicle stimulating hormone and luteinizing hormone. And these are injections that you give in the abdomen. And what they're doing is they're basically growing the follicles in the ovary. So typically in a month, you have one follicle that grows, it's got one egg. What we're trying to do is get 10 or 15 follicles and eggs to grow, and we can then retrieve them in a minor surgical procedure where we use a needle that goes through a vaginal ultrasound probe, and that needle goes into the ovary. We suction the fluid out and get the eggs. Those eggs go to the laboratory. We fertilize them with sperm, either from a partner or from a donor, and then we create embryos. And then those embryos can be frozen. They can be transferred back to the patient in that cycle if they are cleared for a pregnancy, or we can test them. And we can test them for genetics, so for chromosomes like 46XX, 46XY, Down syndrome, or you can test them if someone has a predisposition to cancer. So if there's a family cancer syndrome, you can test for that gene.
Now, just kind of changing tracks, the other thing I know that's happened is I know some kidney cancer survivors who are actually pregnant during their cancer diagnosis. So what are the risks there when you're both pregnant and you have this cancer diagnosis? To both like the risk to pregnancy and also to the, person's life.
Yeah. First, my heart goes out to anyone who is diagnosed with cancer in pregnancy. What a terrifying time. And I think one problem that comes up is that diagnosis may be delayed because you're pregnant, because some of the symptoms of kidney cancer, back pain, a mass, hematuria, blood in the urine, those can be seen in pregnancy. And so the workup of those, the first thought in a physician's mind may not be kidney cancer. You're looking for
Yeah.
other things first, and so it may take a little bit longer. The care of any person who is pregnant and has cancer, would be managed really closely, both with their obstetrician, but hopefully with a maternal fetal medicine doctor as well. So that's a high risk obstetrician. And, we think about a few things when we think about cancer in pregnancy. So first, there are, if you're having surgery in pregnancy, you have to think a little differently about fetal monitoring. So when you are having a surgical procedure and you're under anesthesia, if you are beyond 24 weeks, the anesthesia team and the obstetrics team would want to monitor the pregnancy with fetal monitoring. So it's kind of continuous fetal monitoring in the operating room in case there's any, you know, decrease in the fetal heart rate or any impact to the pregnancy that would require urgent delivery. Now, that would be a rare scenario, but that could happen. And then we, of course, have to think about, is there any impact to the surgery itself to the pregnancy? And probably not. There are some risks of anesthesia that are different in the first, second, or third trimester. We worry the most about anesthesia in the first trimester. The safest time to have surgery is the second trimester, typically.
Could you explain why that is? Like why you're more worried in the first trimester and it's most safest in the second
Yeah. The first
surgery?
trimester is when fetal organs are developing. And so when you think about the types of exposures, the anesthetic drugs that are, going into the system in pregnancy or, in that person's surgery, the the first trimester is when the organs are most sensitive. And really the biggest risk would be a miscarriage, if you are exposed to something that is so toxic. And in the second trimester, it is safest because you're out of that window when the organs are developing, the fetal organs are developing, and the patient is also, physiologically and kind of hemodynamically at their most stable. It becomes very challenging in the third trimester. For example, if you have a patient who is laying on their back with a big fetus laying
Mm.
on their inferior vena cava, which is the big vein that brings blood from the body back to the heart, back to the lungs and the heart. If you're compressing that with your big gravid uterus, that can affect, the blood flow throughout your body and can affect the fetus. The same reason why we tell people to sleep on their side in their third trimester. And, so all of those kind of hemodynamic shifts are more challenging in the third trimester.
So then, so in terms of managing, I guess, cancer while carrying a pregnancy, so if you are in the third trimester when, let's say the cancer is discovered, the kidney cancer is discovered, how should a patient manage it? How should her care team manage that?
So this is, that would be managed by their oncologist and their maternal fetal medicine doctor. So, a little distant from what I'm doing now clinically, but in general, they would think about, are you getting any drugs that could affect the pregnancy? For the most part, they would, continue whatever is required to treat their pregnant or to treat their cancer, and it would be able to be continued safely. I think one of the concerns with these checkpoint inhibitors is that different from most chemotherapy drugs that we worry about exposure in the first trimester. Now we're talking about the chemotherapy drugs, not anesthesia and surgery, but these drugs themselves, if you're giving these immune therapy drugs, they might have more of an impact on the fetus in the third trimester and on the fetal immune system. And so those babies, once they're born, might be monitored a little bit more closely. And so, this is where having high risk obstetricians and oncologists who are comfortable with, this very niche management of cancer and pregnancy is really important.
Well, I appreciate you giving us a little bit more context in that, even though it's outside a little far away from what you're doing clinically. Now, I kind of want to change topics to focus more on the survivor themselves. So, what are some in your practice and working with kidney cancer survivors? What are some of the emotional and psychological impacts do you see like fertility concerns having on these patients as they're dealing both with their diagnosis and wanting to expand their family?
Yeah, I mean, it can't be overstated. When we think about, any patient who's diagnosed with cancer, the obviously it is a life-changing diagnosis. And when we think about anyone diagnosed with infertility, that's a life-changing diagnosis. And when we look at the psychological impact of a infertility diagnosis, it equates to, the tremendous and deep and long-lasting impact of a cancer diagnosis. So these are considered kind of parallel, life-changing, challenging diagnoses. And so when you combine the two, you can only imagine how painful that is. And I have patients who tell me that, again, like when they come in and talk about fertility preservation, this is the thing that they're most afraid of, or that they're most devastated by, that they, can't start their family when they expected to, that, maybe even just delaying pregnancy by a few months or a year or, whatever they envisioned, pushing that timeline is devastating. And you know that from just talking to people who want to be pregnant this month and they have a negative pregnancy test. The idea of waiting another month is really hard. And anyone who's listening to this who's gone through infertility knows exactly what that feels like. It's devastating. And then for someone to say, actually, it's going to have to be a few years, like that is life altering. And so it's not just thinking about, your first pregnancy, but what if you are a parent of one child and you really hoped that your kids would be close in age, and you're now thinking, okay, well, the spacing of my pregnancies is going to be really different than what I imagined. And so even if, the treatment itself may not impact your ovaries, may not impact your ovarian function, there's all of these other impacts to, spacing your family and what this means for kind of what that goal family size might look like. And I think the biggest risk of infertility for anyone is age-related fertility decline. Like we know for a fact that's the case. And so for anyone who is starting their family or thinks they're starting their family at one age, has this new diagnosis, and then has to push that start time back, then that means baby number one might be later. And then ultimately that's going to affect when baby number two happens. And that might affect your future family size because you may just be pushing the timeline so much that you age out of fertility.
Yeah, and that also makes me think about, part of the conversation I've had with other survivors and just, other people in general is that like we're either told directly or survivors have told me that they've been told this is that, well, there's more than one way to make a family, right? And, you could have a surrogate or you could adopt, which are wonderful and beautiful ways to build a family. But I think one thing that we don't talk about in the conversation is the experiencing of carrying your own child. And I think that ends up being impacted too. So I wanted maybe
Yes.
you could expand that a little bit about, just talking to patients about how that kind of plays a role in this conversation of whether or not someone does choose to expand their family based on whether or not they can carry.
Yes, thank you. That was next on my list to talk about because I think you're absolutely right that there's, you know, yes, there are so many ways to build a family. And part of what I am privileged to do every day is help people explore all of those different ways and make dreams a reality using ways that maybe they didn't envision. But that doesn't change the fact that if your hope and dream was to build your family in this one way, it is devastating if that doesn't happen that way. And so I think there's, if someone is thinking about whether they can safely carry or not, we have lots of multidisciplinary conversations with oncology and maternal fetal medicine and think about all the ways that it could impact your pregnancy and can you safely carry and what does this mean for a fetus and for you. Um, But if that can't happen, if the decision is that it wouldn't be safe or that it shouldn't happen, that is devastating. And, absolutely we talk about what that gestational carrier journey might look like, but that's not an easy answer. And it's expensive. Many people can't afford it. It's, I would say the vast majority of patients can't afford it. And, I'm sure anyone listening to this may know these numbers, but if you're working with a gestational carrier agency, we might be looking at 100 to $150,000 to use a gestational carrier. So this is a tremendous burden that most people cannot afford. And there's also the lack of as you mentioned, the idea that you may not experience pregnancy in the same way, and that is, there's a tremendous amount of grief that is carried along with that. And so we have a psychologist built into our program who helps patients as they navigate this, but it doesn't take away that grief.
No, I appreciate you saying that because I think that's also for myself part of the decisions I made. I know I wanted to build my family through carrying my child, and when, you know, that option was taken away from me, if you will, from, or at least I thought it was taken away from me. It's like I kind of came to that acceptance of like, okay, so maybe I'm not going to expand my family the way I wanted to, and maybe I'm not going to, because it is expensive and it's inaccessible for many people. Um, but this makes me think, and maybe it was should have been a question at the top of the conversation, but let's talk about the definition of fertility, right? Like we think of it as maybe just, egg, sperm, but is there a looser definition of fertility? I know we talked a lot about, carrying, whether or not it's safe, also in terms of sperm and egg. But yeah, let's kind of like just talk about what fertility does mean.
Yeah, yeah. Let's zoom out all the
Yeah.
way. And we can talk about, what does it take to build a baby? So we need ovaries, uterus, and sperm. And from the sperm perspective, partner sperm, donor sperm, from an egg perspective, someone's own egg, their partner's egg, a donor egg, and from a uterus perspective, either your own uterus or, someone else's uterus, like as in a gestational carrier. And so all of those components have to be fitting together. And, when we think about the definition of infertility, so technically the definition of infertility is in someone under 35 years old, 12 months of unprotected intercourse without a pregnancy, over the age of 35, 6 months of unprotected intercourse without a pregnancy. Now that's assuming a heterosexual couple, but there are all, families come in all the ways, and obviously, and so there's, someone may not have sperm because they don't have a partner who has sperm, or they don't have eggs because they don't have a partner who has eggs. And there could be, of course, uterine factor infertility, where, maybe your uterus, is, you have a lot of fibroids, or you have tubal factor infertility because, the tubes are blocked, or you may be in a position where it's a safety issue and we've got a medical contraindication to pregnancy. And so maybe all of those components are there, but you've got, this other question of, is it safe for you? And that's where we think about, for all of the above, for all of these causes of infertility, the best tool we have is in vitro fertilization. And in someone who doesn't know, like let's say, you have someone who is early on in their journey and they have this new diagnosis and they don't know what things are going to look like for them in a few years. Can they safely carry? What will treatments look like? You can freeze eggs or embryos, and those can be used either in yourself or in a gestational carrier. And so in some ways it presses pause if you have something frozen so that you can return to them regardless of, what has happened to your ovaries or your uterus or your body.
I appreciate that. Thank you for talking more about it because I think, and maybe for myself and others, I think sometimes when we hear fertility or infertility, we are thinking about it in those terms of like, well, can I, are my eggs fertile or not, right? Like it's not necessarily thinking about like a bigger picture of like, well, can I safely carry it? I wonder, and maybe this is something to answer, or maybe it's just a conversation, but I also wonder if that kind of impacts the conversation about fertility because it could be, I know at times for myself I'm like, oh well, maybe this isn't just an issue of fertility. Like is it okay for me to say it's an issue of fertility just because I'm not maybe not be able to carry safely? Do I belong in that conversation? I think I wonder if
Yeah.
that also stops us, at least, all cancers, but especially for kidney cancer survivors, if that kind of stops us from having that conversation we should be having.
Yeah. No, it's a great question. Like what is, how do you define it? Because it's different than our typical patients with infertility, but it's no, it's no less, it still means not being able to have a child the way you hoped to. And but you're right, the definition is different, and the definition of infertility doesn't really apply, but in the same way that it doesn't really apply for same-sex couples because they can't try for 12 months and then
Yeah.
not get pregnant and have a diagnosis of infertility. And so what becomes complicated from an insurance standpoint is, if you've got someone, so for that example of like a same-sex couple,
Yeah.
insurance might not cover infertility care because they might not deem them infertile because they haven't been trying to get pregnant for 12 months, but they can't because there's two pairs of eggs. And or you've got if you're in a position where you're a survivor and you can't actively try to get pregnant, but because it wouldn't be safe, insurance may not cover your IVF post cancer care, even though the reason you're struggling with fertility is because of cancer. It may not cover you because you've already been exposed to the thing that affected your fertility. So, to clarify that a little bit, let's say I have someone with a new diagnosis of cancer, they might, if they're about to go through some kind of chemotherapy or immunotherapy, fertility preservation often is covered by insurance. If you are in a state where insurance mandates coverage for fertility preservation, if you're in Illinois or New York or any of the states right now where it's covered, you probably have coverage and you can do, a cycle of embryo freezing or egg freezing. But if that same patient completes their cancer treatment and then comes back and wants to freeze eggs or embryos because they still have some ovarian function, but they've got to wait 3 years to get pregnant, insurance probably won't cover it because they are not facing anything imminent. So it's exactly what you're saying, that it's you're in the category of infertility and still facing all the terrible parts of infertility, but it's not necessarily defined in the right way.
So I feel like that comes to the things need to change, right? Like what are some ways that you see need to change in order for us to have this conversation more often and in a more intentional, meaningful way among cancer survivors, oncologists, cancer care teams, and fertility doctors, and I guess even insurance companies.
I think we need more data. So we absolutely need more data about the risks of all of these drugs and all of these treatments on fertility. And I think what happens when you have a diagnosis like kidney cancer, where we have a smaller population of reproductive age patients who are experiencing this, it gets less attention and you know, less research
Mhm.
relative to more, more common diagnoses. And so we know a little bit less. The treatments are newer. So some of these immunotherapy treatments are newer. And so we don't have as much data. And, we have to change how we're studying these. And so in clinical trials, when these drugs are being studied for their impact on every other organ system, we need to study the impact on the ovaries and on the testes so that we know how to counsel patients. And if we better know how to counsel patients, we can demand that these treatments are covered by insurance, that fertility preservation is covered, and that these conversations are had early and often.
So this brings me to oncologists. Now, you talked a little bit about how they're involved, but how are they involved in the fertility discussion, and how can they be better involved in this fertility discussion?
Yeah, I think that they are, we know what the ASCO guidelines are. We know that
Mhm.
fertility preservation should be a part of comprehensive cancer care and that these conversations should be happening. In practice, I think it's very hard for oncologists who are already stretched so thin. So I think the more we can make it easy on them by providing patient navigation services so that there is a touch point. They know who to contact, how to get patients the conversations they need with infertility, with reproductive endocrinology, but also making sure that there's these, bridges from reproductive endocrinology to oncology. It's something that's really important to me that, I direct our fertility preservation program at Northwestern. We have literal bridges all throughout our hospital connecting the fertility center to the cancer center to Lurie Children's so I can see the pediatric patients, literal bridges on our campus connecting all of us. But the majority of people do not have that kind of access. And if you're out in the community and you're at a freestanding center, a freestanding cancer center, and then the closest fertility center is 100 miles away, that will be so much harder. So the more we can offer telehealth and remote monitoring and make things as geographically accessible as possible, and then get it covered by insurance. So have these conversations covered by insurance, make fertility as, as critical and early part of the conversation as all other pieces.
And how can patients, I mean, we have when we're going through it, even after, like we already have the burden of cancer on us, but there is a part that we can play too. So, what would be your advice to patients who have fertility on the mind, have pregnancy on the mind, have expanding their family on the mind? What can they do to advocate for themselves with their oncologist about getting this fertility counseling?
Yeah, so I think that either you bring it up directly to your oncologist, which is always a good idea, and maybe your oncologist has a recommendation of who they are connected with in the reproductive endocrinology space to refer, or just call a fertility center. Any fertility center has the ability to freeze eggs and embryos.
Mhm.
And so even if you don't think you are, infertile, and you don't feel like you belong at that fertility center, and I've had patients say, they kind of qualify why they're in for a visit. I know that I don't really have infertility, and so I don't know if I should be here or not. And so I have to kind of, squash that early and make sure patients understand you should absolutely be here. I'm so glad you're here. And, I'm so glad we're having this conversation. And even if it's just a conversation about these treatments will not impact your fertility and we can feel reassured, fabulous. I want that patient to have that conversation so they can feel reassured. Maybe we can get some early ovarian reserve testing. Maybe someone comes in for a conversation, they don't think that their treatment will impact their fertility at all, but it turns out they have, a really low ovarian reserve for some other reason, and they should preserve their fertility because of their age. So I actually think everyone should have conversations about fertility regardless of where they are in their cancer journey. I just think anyone who's thinking about having a child at some point is at risk of infertility.
I was gonna say, like, I appreciate you saying that because I think that is, I think in a lot of ways, survivors can stop themselves
Yeah.
because there are just internalized messages about their own journey and what there are. So that I feel like you just saying that, yes, you should absolutely have it, even if you don't believe that you should be, is just empowering. I hope is empowering for the patients listening because it is an important conversation. And I know we have a few minutes left, but I have one question, not necessarily a closer, but it's something I'm curious about. I've heard from other survivors about getting conflicting advice from, their oncologist or maybe their gyno or like this doctor and that doctor of like, yes, you're safe to do it, but then someone's like, no, you're not. How do you navigate that? Like, how does a patient navigate conflicting advice among different parts of their care team?
That's a great question. I have had patients who, if they are given advice from one oncologist that they can proceed with some kind of care, um, and then they have another, a kind of conflicting advice from another oncologist, maybe they'll get a third opinion. I think part of it too is there is some degree of risk in everything we do. And so, I think it depends on what the risk is. If is this a potential risk to the fetus to be pregnant? Is this a potential risk to you in not being able to treat your cancer appropriately? And that might dictate then who you talk to for additional advice. Are you talking to an obstetrician about the risks of pregnancy? And so I think that there's a piece of it that, as the reproductive endocrinologist, I'm a little bit of the middle person where I might be talking to both the oncologist and the high risk obstetrician in terms of can we safely freeze embryos, first of all? And then can those embryos be used in this person carrying a pregnancy or not? And so maybe we think about, let's just start with step one, preserve fertility. And then down the road, when you're closer to wanting to be pregnant, then we reassess and reevaluate can you carry the pregnancy or can someone else? So I think that it doesn't always have to be all the answers all at once. I think, when I'm finishing like an initial consult with a patient and, they're totally overwhelmed by all of these things that are swirling in their head about fertility, and maybe like they haven't thought about reproductive biology since like high school biology, and this all feels like a new language. All they have to decide is, is it important to you to try to preserve fertility? And
Mm.
and if the answer is yes, then we preserve fertility. We do the best we can to freeze eggs or embryos or sperm. And then all the other questions will fall into place. But I think it's what's hard, and I'm sure what is so hard when you're newly diagnosed with cancer is you've got, you know, 10,000 new questions that you never thought you'd have to ask. And most of those things are not going to have quick answers, and they're going to kind of unfold as time goes on. And I think the biggest thing is just, do you want kids? And then we have a conversation rather than trying to put all the pieces together all at once.
Well, thank you so much for joining us. Now, before I let you go, I always like to ask, is there anything that you'd want to bring up that maybe we didn't touch on in our conversation?
No, just thank you so much for having me and inviting me. And, I just hope that listeners are empowered to think about their fertility and ask as many questions as they feel like they need to.
Definitely. No, I thank you so much for coming on because I know that this is a conversation that so many survivors in the kidney cancer space have wanted to have. And I've heard the frustration from so many who are like, this is just a conversation we're not having, especially as many more young people are being diagnosed with kidney cancer. It's just not a conversation we're having. So I appreciate that you being open to having the conversation with us. So thank you.
Thank you so much for having me.
Thanks for listening to Kidney Cancer Unfiltered. If you found this episode helpful, be sure to like, share, and subscribe wherever you listen to your favorite podcast. For more resources and episodes, visit kidneycancer.org or follow Kidney Cancer Association on social media. Until next time, take care, and remember, you're not alone.